clinical study follow-up length. I think there's a lot of literature where it's 6 months and less. There's some recent literature where we're all the way out to 2 years. That includes some of your work. That includes Mark Little's work. Interestingly, in your recent paper, Sid, you talked about a little bit of waxing and waning symptoms kind of early in the postoperative period in those first 2 months. Is 6 months enough, or should we really be shooting for clinical study follow-up length in the 12 to 18 to 24 month range? Sid, you got less than 6 months. I'm going to give you the tough one here. So I'm going to give you greater than 6 months. The three of us have had these conversations before, but I'm curious, as we continue to move forward, what you think now.
The key thing about less than 6 months is that your compliance rate is high, right? You do 100 patients, you're going to get 95 to 98 to answer your questionnaire and come back in and so on. And then it becomes, if you're going to do 100 patients on a study to try to follow them all out to 2 years or 3 years or whatever, it's extraordinarily resource intensive. If you're doing it as part of a trial and you have to look at your own budget, I can tell you that so our trial, we're doing 2-year follow-up. The budget goes up astronomically when you're talking about a 6-month follow-up versus a 2-year follow-up. It's basically, it's double. It's 2.5 times the cost, right? When we're trying to be cost conscious. So that I think is while I believe in longer term follow-up, I think the best advantage of a short-term follow-up is that your compliance rate is high.
I would probably argue, again, I think Sid, you and I probably feel very similar about this. I think maybe some caveats I would add are, we're currently in a relative vacuum of data. So I think any data is good data right now for GAE. We don't want people just doing GAE and not publishing their outcomes because we still have such a long way to go. I think the reality is we need all lengths of data. Long term is obviously going to be great. And I think talking to more orthopedic colleagues, that's what they like to see. And talking to more rheumatology colleagues, they actually like to see or want to see or need to see more short-term data. So their bar is much lower, at least in conversations that I've had. And as Sid said, doing the short-term data is going to be easier to do from a practical standpoint and also compliance standpoint. And if that's where the bar currently is, then by all means, at least let's get that data. But ultimately, as the field matures, we will need longer term data to sort of assess not only efficacy, but again, it always comes back to safety. People still are concerned about this procedure 2-3 years out. Can I get my knee replacement? will this cause some long-term bone infarction or whatnot, So I think that's where we need long-term data validation for that.
And I just to argue against myself and on Oz's side, the long-term, a lot of people think this is placebo, right? They think this is fake. If you go from a pain of 8 out of 10 to 2 out of 10 at 3 months, okay, maybe. I find it hard to be placebo. If you go from a pain of 8 out of 10 to 2 out of 10 at 2 years, do you really think that would be placebo? And some 70-year-old guy who's got chronic arthritis, pain-free 2 years later? How is that placebo? And if that's the case, then we shouldn't practice medicine in it at all, right? We should just give placebo to everybody for everything. So what happens is that duration of placebo, there's all these studies looking at placebo effect, and they're all over the place. That duration of placebo, best estimate is on the order of months, right? 3 to 6 months. I'll give you kind of an example. So if you can stretch out your study longer than 6 months, you start to overcome your placebo effect. So that's number one. Number two, when we talk about competing therapies, joint injections, gel injections, platelet-rich plasma, stem cell, genicular nerve ablation, all that stuff is 3 to 6 months. There's nothing past 6 months. So if you can prove that this therapy works at 12 months or even at 24 months, you can't, imagine doing a trial of GAE versus corticosteroid injection and your endpoint is 24 months, right? That's, you can't. Steroid injections, which is standard of care, can't compete with that, right? So I think we actually have a big advantage to look at long-term data because the nice thing about GAE is that it lasts a long time. That's the greatest part about this, that you can tell patients that I'm not interested in a short-term Band-Aid. I'm interested in getting you duration of response that's not measured on the order of weeks or months. I'm interested in getting you a duration of response that's measured on the order of years. And that is a very powerful message that we can tell the medical community and to patients, and we should take advantage of that.
Yeah, those are great points. And this comes up a little bit with new devices that are coming to market as well, right? because there are a lot of pathways to clearance and FDA approval. What is the benchmark for preclinical and clinical data for some of these new devices that are coming to market?
Are you talking about for GAE or for other stuff?
For
Okay.
GAE.
So,
Yeah, for GAE
I know
specifically,
there's
sorry.
another device that had 36-hour outcomes. This is not that. I think the FDA has probably gotten more GAE submissions than they care to deal with. I'm guessing at this point, they're like, oh my God, another one, right? And so I think their thresholds are probably getting higher and higher. I would say at the very least, 6 months is going to be the minimum endpoint.
For clinical data.
But, I would say anywhere 6 to 24 months is probably like where the federal government is shooting for. They do seem to be a little bit they changed the goalposts, right? Which is not fair, but this is reality. So 2 years ago, it might have been 6 months. Now it might be 12 months. Next year, it might be 24 months. So,
But you're talking about a clinical IDE trial, right?
clinical IDE trial, but at the same time, this is what we should be aiming for, somewhere in that range.
And every new device coming to market, do you think that needs to be done?
That I don't know. Oz, what do you think?
Yeah, I think if you talk about FDA regulatory, I think, again, it goes back to all they care about is safety. They don't care if it works, probably. They care more about that you're not harming people. And so I think I agree with Sid that they want long-term follow-up data for that reason. So, I can only speak to my own experience dealing with the FDA. We're running a 3-month outcome trial, but they still want 12 months of data. They want those patients followed for at least a year to make sure that nothing bad happens to them out to that point. So I think the bar is probably in that range.
And you could do, it's exactly the same. So hours, you can do your primary endpoint at a shorter time point, but you make your secondary endpoints longer, right? So ours is like a primary endpoint at 6 months. Secondary endpoints are at multiple time points all the way up to 24, right? So you don't have to necessarily do your primary outcome at 2 years, because then you're like, great, I got to wait 2 whole years for, to get results, right? So you can kind of compromise that way.
That's a great point. Okay.